Hi there, I'm Fernando Bernal. Welcome to the Physiology Matters podcast. Today's episode revolves around the topic of cranial electrotherapy stimulation. The use of electricity as a form of therapy is not new. It's as old as the electric eel, which was used about 2,000 years ago by the ancient Egyptians, the Romans, the Greek, for the treatment of pain. Fast forward to our current times with modern technology and a better understanding of the brain has led to creations of devices that can deliver current into various regions of the brain in an effort to treat various conditions of neuroelectrochemical origin. One such device is the Alpha-Stim. Today I'm joined by Dr. Josh Briley.
Briley, yes.
PhD, who is the Clinical Education Director for Electromedical Products International, Inc., the manufacturer and distributor of the Alpha-Stim devices. Dr. Briley is a licensed clinical psychologist. After earning his doctorate in clinical psychology in 2003 from the University of North Texas, he began his career at the Federal Bureau of Prisons, where he focused on drug treatment, crisis intervention, and anger management. He was quickly appointed leader of the crisis support team for each institution he worked in, as well as appointments as regional assistant team leader. Dr. Briley then transferred to the Veterans Health Administration, working in a small community outpatient clinic in Central Texas, where he specialized in individual and group therapy for PTSD, depression, anxiety, and chronic pain treatment. Dr. Briley has also owned a private practice, taught online undergraduate and graduate level courses, and conducted teletherapy for BetterHelp.com. He currently serves on the Daily Life and Workplace Stress Board for the American Institute of Stress. Dr. Briley, thank you and welcome.
Thank you. It's a joy to be here.
Good. Could you give us an idea, what is the difference between a clinical psychologist and a general psychologist?
Really, so like the difference to me would be more like somebody who has a doctorate in counseling psychology versus clinical psychology. So clinical psychology focuses more on the more serious mental health issues, schizophrenia, bipolar, more the personality disorders. Not that counseling psychology doesn't. I'm not trying to diminish any of my colleagues out there that are in the trenches doing hard work, trying to help people live their best lives. The counseling psychology, at least in my experience and, talking to my colleagues and my co-students at North Texas, their courses were more in like family therapy, kind of general, everyday stress-related things, as well as, the mental illnesses as far as depression, anxiety, PTSD, substance use, all of that. So it's just very slightly different training backgrounds is all.
I see. So it would you say then that a clinical psychologist is a step before a patient may have to use some type of pharmaceuticals and go to a psychiatrist or something like that?
Actually, it's generally the other way around, at least in this country. And in most Western societies, generally we get referrals, and it's clinical or counseling psychologists, LCSWs, LMFTs, anybody out there doing therapy. We tend to get referrals from either psychiatrists or from general physicians who have already prescribed medications, and then they know that therapy can help with that, or the patient doesn't want to take medications, and so they're referred for therapy. So.
As a clinical psychologist, how do you integrate Alpha-Stim into your practice in the clinical setting?
Okay. So I actually began using Alpha-Stim while I was at the VA. So about 2018, I believe, is when I finally was able to kind of get my hands on one, start using it with my patients. And I just incorporated it into the normal services I was already offering. So I had 9 therapy groups a week. I had, individual sessions throughout the day, crisis intervention sessions. And so I would offer them all an Alpha-Stim to use during session. They could put the ear clips on, we'd set it, make sure we had it set correctly for them. And then, we'd go on with group or individual as normal. And with my VA, I had to do 2 trials before I could order a device for a veteran. So we would just do it during our normal course of, during our normal sessions. And then I would document, their pain rating, their emotional distress rating before and after, demonstrate, document that I had trained them how, and then they had shown me how to use it. So they had proficiency with it. And it worked well enough, like word of mouth got out among my veterans. And it went from, especially here in Texas, mental health is always kind of a last resort. Like I'll go see you when I've, as like the last thing before I just completely lose it. Right. Texas very much has, and for better or worse, Texas very much has a pull yourself up by your own bootstraps mentality. And especially when you're dealing with an alpha male type population that veterans tend to be, talking about people, sharing your emotions, admitting that you're having a problem is hard and feels like a weakness. So they, it's kind of our last resort thing. And so I went from, oh, you're the psychologist, I don't want to talk to you, or I'm only here because my doctor is requiring me to come see you once a year, to and that definitely wasn't my experience with everybody. I mean, I had well over 150 people on my caseload at any one time, with between groups and individuals. So, it's not like I was sitting there doing nothing. But all of a sudden, I became the most popular provider in the clinic because word of mouth was getting out about this Alpha-Stim device, and how much better my patients were sleeping, how less keyed up they were all the time. The veteran spouses were talking to each other. And, oh, you've got to send your veteran in to go see Dr. Briley because he's got this magic box that makes everything better. And so all of a sudden I became very, very popular. And some people only came in, got the Alpha-Stim, and then I would only see them like when they came in for something else in the clinic. But a lot of people I was able to get plugged in to my normal services as well. So it actually incorporated very, very easily into what I was already doing. And then I found, many of my veterans were able to at least come down off their psych meds. A few of them kind of came off of them completely, came down off needing narcotics to maybe just, less addictive pain meds or even no pain meds. So it really was a game changer. I was telling everybody about it. I told all my colleagues in the clinic, all the physicians and nurses, got them all hooked up on it so they could see what it was like. Started telling my other psychologists and other clinics in the Central Texas VA system, and kind of helped them get established and showed them kind of my templates and how I was using Alpha-Stim. So I got them to be able to offer it to their veterans. And it just flowed very, very easily into how psychology was already doing things within the VA.
So did they take the unit home, or it was only used when they were in session with you?
So this is one of the things I love about Alpha-Stim is it's designed to be used by the patient at home. So I would do the 2 trials in the clinic, which is the least I recommend for any provider to do. That way you show them how to use it, and then they show you they know how to use it. And then plus you get a chance to see, how well they're going to respond. And so that way, that you aren't giving them something that's just going to sit on the shelf. You are pretty sure that they're engaged, they're going to use it. And then prosthetics would order one and ship it to the veteran. And a lot of them would, they used it every day, every other day at home. And a lot of them would bring it into session with them. And so they would put it on during their group sessions, they'd put it on during their individual sessions. And what we found was when they did that, when they wore an Alpha-Stim during session, we were able to get into the meat of their problems a lot quicker and easier. Because, when you're coming in to talk to a therapist, you're not coming in to talk about the good things that happened to you in your life. You're coming in to talk about the painful things that are very emotionally driven, very emotionally laden. And as you talk about them, the emotions come up. That happens with any strong memory. So an example I give patients is, if you really kind of bring up the memory of your firstborn child and start to talk about it and start to tell people about it, those emotions you felt that day also come up. The excitement, the nervousness, the happiness, assuming it was a good experience. All of that comes up, but because it feels good, we don't stop it. So we don't think about it. But if you're talking about a painful memory, those emotions come up, but they're painful. So we push them back down and we try not to think about it, try not to talk about it. So when you're in therapy, those are the very things we need to talk about. And when those emotions come up, one of my veterans described it as holding a beach ball underwater. You can do it for so long, but the longer you do it, when you finally lose control of that beach ball, it's going to come, if you just push it down, let it up, it's just going to kind of bounce back to the surface. If you hold it under for a long time, when it finally breaks free of your grasp, it's going to come up and hit you in the face. And I thought that's an excellent analogy for kind of when most people come into therapy the fourth or fifth time they've been hit in the face. And they still, and they bring that method of trying to deal with the pain into therapy with them. So they know they need to talk about it, but it hurts and they don't want to talk about it. And then when they do talk about it, all the emotions come up. And especially with the population I was working with, there's a lot of anger behind what happened to them. Either they felt like something didn't go right, or their buddy that got injured or killed shouldn't have, and they're blaming somebody or they're blaming themselves. There'd be a lot of sadness and depression that came up, and it would get overwhelming and flooding. And there were several times where, I would keep them in that moment for a little bit. And then I'd be like, they're getting to where they can't handle what they're feeling. And I didn't want to have them walk out more emotionally unstable than they came in. So I would stop the session. We would de-escalate. We would calm down, kind of shoot the breeze a little bit. And then that would be the end of the session. With Alpha-Stim, that didn't happen. So they would still feel the emotions. They would talk about what they went through, no matter how painful it was. Tears would flow. You could see their teeth would grit if they were angry. They'd clench their fists. They felt it, but they were able to talk about it, talk through it. And then when the story was over, they kind of naturally de-escalated and went back to calm on their own. And I heard parts of their experiences that I had never heard, even after almost a decade of working with some of these men. And they progressed so much more quickly. And there were a few that I actually saw once we, kind of worked through, okay, there's this, what we call the index trauma. So the index painful event. And then once they got that dealt with, another one would pop up and be like, okay, my turn. And the theory in working with somebody like that is that each successive one is supposed to be easier for them to cope with and process and deal with. That's not actually my experience. The emotions are painful regardless. And so with Alpha-Stim, they were able to do that much more quickly, much more easily. And it just made their life better. It made my job easier, made our time together way more productive. And that's one of the reasons why I was reaching out to everybody I knew going, you've got to try this with your veterans. Trust me, it's right. This is amazing.
You answered a question that I had already, and that was, if you're in therapy and you are talking about things that are painful, trauma that you might have suffered either at the war or home or whatever situation you were in that really made an impact in your emotions, and you're talking about these things, that I would think that there would be a conflict in the brain with the chemistry that the emotions bring about, while Alpha-Stim is trying to regulate that. And it's fascinating, but I'm not quite sure I understand the whole process.
All right. So speaking neurologically, the nervous system is electrochemical. And in Western medicine, we focus on the chemistry. We focus on the neurotransmitters. We focus on the brain chemicals, all of that. And that's important. I'm not saying it's not. but the chemistry is controlled by the electrical components. So, the way a nerve cell works, an electrical current travels along the body of the nerve cell, reaches the axon terminals, the receptors open up, the neurotransmitters flood into the synapse, they activate the receptors on the other nerve cell, build up a charge, and then that charge fires down the next cell. So the types and the amount of neurotransmitters that go into a synapse are at least somewhat dependent on the intensity of that electrical charge. And fMRI studies have shown different imbalances in the electrical functioning of the brain that we can tie to different emotional states. So, for example, with depression, symptoms of depression are ruminating, turning inward, kind of lack of activity, lack of social things that seem as fun or as enjoyable as they that you used to enjoy. They're not as much anymore. And what they found with depression fMRI studies is that the parts of the brain that are involved in that ruminating and looking inward and it's just kind of feeling down and sad are very hyperactive, while the parts of the brain that are active when we're very social and outgoing and engaged and doing things that we enjoy doing is very underactive. And it's the same thing when you're talking about an experience. So if you're talking about an experience that makes you anxious or scared, that part of the limbic system, those parts of the brain get activated, and that electrical, and your brain starts firing those electrical signals. If they're firing too many electrical signals, if those areas are overactive, then you're going to feel that emotion even more intensely. Whereas with Alpha-Stim, all we're doing is balancing the brain. So we're sending a wide range of biological frequencies that activate the nerve cell receptors and either stimulate or inhibit the nerve cell activity depending on what needs to be done. And the nerve is the one that decides that. So if a nerve is hyperactive, it's not going to respond to frequencies that would make it more active. It's going to respond to frequencies that calm it down, and vice versa. So in therapy, as the cell starts to get, those cells start to get really active and those parts of the brain get to be, kind of hyperactive, if they have the Alpha-Stim on at that time, it helps to bring that back down, and they're able to still feel the emotion. It doesn't completely flatline it. It doesn't make them an emotional zombie. They're still able to feel it, but they feel it at the appropriate level. And instead of being flooded and overwhelmed by it and kind of, having their sympathetic nervous system activated to the point where they just can't function anymore. Or they just want to, run from the room or, defend themselves. So Alpha-Stim helps to balance all that out and lets them get through it.
Would you say then that, would it be fair to say that Alpha-Stim works similar to an adaptogen? Like L-Theanine, for example. L-Theanine in green tea is known to bring down cortisol and perhaps supposedly it increases alpha brain activity when taken regularly. Would you say it's similar?
So that would be a good comparison, I believe. We do have EEG studies that show Alpha-Stim can increase activity in the alpha wave frequencies, kind of induce that alpha state, that relaxed, calm, kind of tranquil feeling, but also tends to decrease delta wave activity, especially in the frontal lobe right here behind the eyes, so that you feel very alert and focused. But there again, we've also have studies that show if people started with high levels of alpha activity, by the end of the treatment, that alpha activity has actually decreased. So it's not forcing a specific response. It's not forcing a specific, it's not inflating alpha activity regardless of where the alpha activity starts, if that makes sense. It's literally just bringing it into that zone where you're in the alpha state.
Is the patient more suggestible at that point? It's like a form of, would you say, electrical hypnosis?
No, I wouldn't say that. Their defenses were down, so they were more able to participate in the therapy process. So, for example, in one of my PTSD groups, I had a veteran who, great guy, loved him to death, but he was the class clown. So if things got really heavy, really intense, I could almost set a watch by the fact that he was about to say something humorous and inappropriate to kind of break the tension. And that was his way of coping with things when he got uncomfortable. Right. Worked with this man, with this group actually for years. And then one day he came into group. He was about mid to late 40s, I would say. And he'd had like 5 back surgeries by then. He came into group one day and it was a bad pain day for him. He was just moving very slowly, walking hunched over, barely moving, kind of shuffling his feet. And one of his fellow group members had brought in an Alpha-Stim that the VA had just sent him through neurology. And he didn't remember having gotten it. He didn't remember talking to anybody about it. He just walked in and he was like, "What is this?" And I was like, "Oh, it's the Alpha-Stim." I didn't have one in my office at the time yet, so I was kind of all excited to see one. And he was like, "I don't know what it is. I don't know how to use it." And neurology had helped another veteran get one, and so he knew how to use it. So he was like, "Oh man, I'll show you how to use it. This thing's amazing." And the guy who brought it in didn't want to, but this guy with the class clown and the bad pain that day was like, "Hey man, I'll try anything." So we put it on him, and I noticed about 5 minutes into it, he just kind of sank in his chair and was just very calm. And then I noticed that he was engaged in therapy. He was making comments. He was helping, respond and help people. But it was all 100% on point, not at all distracting, not at all his normal behaviors. And I'm like, okay, that's interesting. I didn't have a lot of experience with Alpha-Stim at the time. So then we finished the treatment. He only needed a 20-minute treatment. And, took the ear clips off. The guy who brought it in was like, "Okay, yeah, I'll try it." So we put it on him. At the end of the group, about 30 minutes after his treatment had ended, this man stands up, looks really confused, and sits down. And I'm going, "Dude, what's up?" And the whole group stopped because this was a very close-knit group. They all loved each other, supported each other. It was amazing to watch all of these veterans come together and support each other. It's one of the reasons I did so many groups. I love seeing that dynamic. So they, of course, all stopped to see what and what in their minds their brother needed. And he stood up and he kind of stretched and he stood up really straight. And he was like, "Guys, my back doesn't hurt." And I was like, "Really?" And he goes, "Yeah." And I'm like, "Well, I said, how are you feeling emotionally? Because you weren't a cut up in group today." And he's like, "Yeah, I feel really calm and relaxed." And I'm like, "Okay, great." And so then of course everybody wanted one because
right.
So I have seen that where like their defense mechanisms won't be as high. And so they're more engaged in the process, but I wouldn't say more suggestible.
I see. So years ago, I was working in Wilmington, Delaware, where I worked in an outpatient clinic for substance abuse. Mm-hmm. And I was doing auricular acupuncture at that time. And there were some patients that began to say that they were having hallucinations after the treatments. I don't know why, but they were saying that. So we had to kind of monitor who would be more susceptible to maybe, even if it was in their mind fantasizing that, we had to watch out who we did these treatments to.
Right.
Who would not be a good candidate for Alpha-Stim other than someone that may have a pacemaker or something like that?
That's really about it. So somebody with a pacemaker, a defibrillator, maybe a cochlear implant, that's the only contraindication for an Alpha-Stim. Other than that, it's a very gentle treatment. It's a very safe treatment. Our side effect ratio is 0.11% of the time over the last 10 years. And I know that because I'm the one who runs those numbers. So as of last year, at the end of last year, we'll see what the ratio is this year. But when you look at, number of units that we sell versus number of adverse effects reported to us, it's an extremely low number. It's at 0.11%. We've never had a significant or serious adverse reaction ever reported. We've never had to report anything to the FDA, which, you report to the FDA when there's a serious injury or they have to go to the hospital because of your treatment or something like that. We've never had to do anything like that. What we do tend to find is people may have a little bit of dizziness or headache after treatment. Generally, that's because they had the current turned up just a little too high. If they'll put the ear clips back on, turn the current down, let it run for a few minutes, then that headache or dizziness will go away. A couple of minutes after that, they can turn the device off. So other than that, we're effective for about 85-90% of people who try it. One survey we did recently showed about, and again, depending on what indication we were treating, anxiety, depression, insomnia, or pain, but the range was between 85 and 94% had at least a 25% improvement in their symptoms. So,
in my practice, I treat mostly pain of different types, chronic, acute, and so on. You mentioned the gentleman that stood up and said his back pain was not there.
Right.
But he wasn't doing local treatments for pain with Alpha-Stim, with a pain module. It was strictly just the cranial stimulation, correct?
Correct. And to be clear, CES isn't cleared for pain in the US. It is in Europe. So that is off-label to use only the ear clips for pain. I was trying to treat his anxiety, and the pain was just kind of a nice little benefit, the pain relief.
Right. So his pain then perhaps was something brought on by muscular tension from stress and what have you. And when he felt more relaxed, perhaps more endorphins were being released, and that kind of there was no follow-up.
Yeah, definitely an increase in endorphins. We've seen that not necessarily with Alpha-Stim, but with CES technology in general. But also, pain is processed in the brain. And so by balancing the central nervous system, we help modulate that pain response. So we calm that area of the brain down and the sensation of pain goes away. Cognitive behavioral therapy for chronic pain research shows about 84% of our perceived pain has nothing to do with the severity of the injury and everything to do with the value we give it and how active our brain is in processing that. So by calming that down, just doing that alone, we're able to alleviate a lot of people's pain. But once you do the local treatment with our smart probes or our AS-trodes, I've gotten people with severe chronic pain, when I see them and I'm treating them and they'll rate their pain at a 7 out of 10, 8 out of 10. Then I'll do a probe treatment, usually less than 5 minutes, more usually around 3, and their pain levels are 2 or below. And then you follow up with the ear clips to get a complete, not just peripheral nervous system, but central nervous system treatment as well.
That was my question next on that. If you're doing local treatment, say you have elbow pain or knee pain, and you're doing a local treatment, what is the mechanism for that to relieve the pain?
Okay. That mechanism is called Microcurrent Electrical Therapy. It's the same with Alpha-Stim. It's the same waveform that we use for CES for the brain. It's just delivered in a different way. And so we put the same waveform into the nervous system. If you're using our smart probes, then it's 10-second increments, and then the device actually waits for you to make a new connection with the skin. and you're just treating all around the area of pain. And it's the same process as with the nerves in the brain. You're just balancing out that nerve signal. So, instead of the pain signals firing, and being very, very hyperactive, you calm it down. And a lot of times we see a reduction in inflammation because the body is able to kind of relax and start, kind of working on that area the way our bodies are designed to. Oftentimes we see increased range of movement, and definitely reduction in pain.
Is this mediated by through C fibers, or what type of nervous fibers will be involved in making that connection afferent towards the brain? It's obviously not just be a local cellular reaction. There must be some type of nervous pathways like C fibers or
yes. So we follow the nerve. So you follow, the electricity follows the nerve pathway, and just like electricity, getting in contact with the wire, it travels in any direction that wire is going. And so the same is here. Once you get the probe on the skin, the current goes down to the nerve cells, and it travels. So you treat your left knee, for example, that current is not just staying in that area. It's following a nerve pathway up through your spine, making the cross, going into the opposite side of, the opposite hemisphere, as signals do. So that's why, when you're doing an Alpha-Stim, a local treatment for pain, you don't just want to treat the side of the body that hurts. You want to treat both sides, because you want to get that balance. So you want the signal to go to both hemispheres of the brain. You want all of the nerves to be, sending the same signal, which is that, everything's functioning the way it's supposed to.
So I would think that this will happen more through the more myelinated type of fibers than the non-myelinated fibers. The electrostimulation, would that be enough?
I would think so. We don't have, data down to that level. Wish we did. We're as we get more and more sophisticated, we're going to do better and better studies. But yeah, so that would, just knowing the way, nerve fibers work, then I would say you're probably right on that.
Yeah, we have the whole gate theory.
Yes.
At the segmental level and so on. So, like in chronic pain, oftentimes the patient develops central sensitization, and the threshold for pain lowers, and any kind of stimulus is going to feel very magnified, allodynia type of thing. Mm-hmm. Is that when you would then consider including, not so much to treat the pain, but including the cranial approach along with the local?
Well, you always do CES when you're doing the MET treatment. It's always there's 5 steps in an MET treatment, and the ear clips CES is always number 5. The first is to do kind of a big X. So, if we were to treat my arm, I don't know how well you can see what I'm trying to do.
I can see.
You would put a probe like here on the shoulder and then down here to this wrist if we're treating my elbow. And then after 10 seconds, you would switch it so that you've got that X. Okay. Then you would zero in on my elbow, and you always want the probes on opposite sides. So you'd put one here and one here. And then after 10 seconds, you would move and do the opposite side, the opposite X. So I like to do like a small X and then across. So it would go through this way and then above and below. And so that's step 2, that small star. Step 3 then is to do a small X on the opposite elbow. That way you start getting that balance and start getting the signal sent to the opposite hemisphere. And then step 4 is you connect both sides. So you would put a probe on the tip of each thumb, index finger, so on and so forth, to connect both sides, get that current going up one arm, across the spine, down the other arm, and then back. And then step 5 is the ear clips.
Interesting. Any studies done on the treatment of phantom pain with Alpha-Stim?
Not studies, but we have some clinical experience in treating phantom pain. And it works really well because, again, we're just calming down those nerves that are firing, and basically phantom pain is the nerves firing, going, hey, something's supposed to be here. So it feels like something is there. When we get those calmed down and they're functioning optimally, then that sensation goes away.
Interesting. I use a mirror sometimes.
And I actually was speaking to someone yesterday at a clinic, and they were talking about using a mirror to treat that phantom pain, and put the mirror up and say, okay, wiggle your toes, and the perception is you're wiggling the toes that aren't there anymore. And it was an interesting discussion.
Yeah, it is. And I have seen interesting results. Mm-hmm. Not always, but a few times I was blown away by how the patient felt afterwards. And I mean, you try whatever you can to help a patient. Exactly. And even if it's not something that has been empirically observed to work, you try things to help. Mm-hmm. And I did see that make a difference. I didn't do Alpha-Stim, but other modalities, but it did make a difference. Let me ask you something about depression, anxiety, and insomnia, for which the unit has been cleared.
Right.
When I use my unit, it's not upside down. I don't see any settings for each individual condition. So would you say that what Alpha-Stim is doing is targeting regions in the brain that has large neurological real estate upon which all of these conditions arise? Because, you have anxiety, which may be having something to do with adrenaline, epinephrine, while another situation may be deficiency or not enough serotonin. We'll discuss that in a minute.
Yes.
So there is no setting. Are we saying that one size fits all with this?
It's not quite one size fits all, but the differences are in the individual, not in the indication. So, and I don't know what settings you use with yours.
I don't have any settings. All I really have is the current.
Current, yeah, that's what I meant. The current
and
the time.
Right, got it. Right.
So to treat all three of these indications, anxiety, insomnia, and depression, what you do is you put the ear clips on, put the conducting solution on the pads, put the ear clips on, and then turn the device on, turn it up slowly until you feel a little bit lightheaded or dizzy, like you just, like you stood up too quickly, that kind of, whoa, I'm, not like you're about to pass out. It's not that strong, but it's just kind of that, oh, whoa, lightheaded feeling, or an unsteady feeling like you're standing on a boat in the water. Some people even physically kind of rock back and forth when they hit it. It's not a subtle feeling. A lot of times when I'm showing somebody the Alpha-Stim the first time, and and I'm telling them, okay, turn it up till you feel that. You can tell they're really focused. Am I feeling it? Am I feeling it? And I'm like, you don't have to do that. You'll notice it. Everybody's threshold for that is different. So some people like me can't even do 100 microamps, which is a 1 on the screen with the ear clips. I actually have to use the electrodes and put them on my shoulders and get my treatment that way because I get dizzy even at a 1. Other people can go all the way up to 500 microamps and not feel the dizziness, not feel anything. So for the people who can only tolerate between 100, 200 microamps, they'll need to treat for 60 minutes. For people who can tolerate 250 microamps or higher, and we don't really recommend going higher than 400 microamps. There's not much clinical benefit to that last 100 microamps. You just burn the batteries down faster. So, the recommended range is between 1 and 400 microamps. Between 250 and 400 microamps, you generally only need about 20 minutes for a treatment. So that's where the difference comes in. But it does treat anxiety, insomnia, and depression all at the same time. So, and again, it does so by just having this global effect on the nervous system. So when the ear clips are on your earlobes. The current travels along the eighth cranial nerve through your inner ear to your brainstem. And then once it hits your brainstem, it spreads to the entire brain. And so any part of the brain that's hyperactive, which you see with anxiety, you see with chronic pain, and like I mentioned earlier, you see with some symptoms related to depression, then it calms them down. Any areas of the brain that are underactive, it brings them up. And so you just get that balancing. Unlike a medication, a lot of people are like, well, if it treats insomnia, it must make you fall asleep. It actually doesn't. But sleeping well is part of a healthy functioning nervous system. And so that's how it does that. And sometimes it does it the first night. Sometimes it takes it 6 weeks before you start to really see a benefit with sleep.
On a daily basis?
On a daily basis. Mm-hmm. So
let me backtrack a little bit back to the VA, because I think it's good to know. Does the VA cover this for the patients, for the vets, or they have to buy it themselves?
The VA covers it. Of course, the saying is, and anyone who's been affiliated with the VA always smiles when I say this, because I heard it from them. If you've seen one VA, you've seen one VA. So I was fortunate. The Central Texas VA system, once they kind of, they had it for a few years before they really kind of found where it fit. I think they tried it with neurology for a while. They put it down to the primary care practitioners for a while. And then I was able to get mine through a pain management pharmacist who worked for mental health. And he recommended to his leadership to our leadership, I also worked in mental health, that I be allowed to use a device in my clinic, because I was sending everybody to him. So he was like, hey, Dr. Briley needs one so that I can treat someone other than my Brownwood, than his Brownwood patients. Brownwood was the little town I was in. And so once they found where it fit, then, more providers were able to use it and get it to more veterans. I know the North Texas VA system, my dad's a veteran. He's in that. To get his device, he went through, I believe, pain management, and his physical therapist showed him how to use it and ordered one. So it's, every VA is different, and some VAs don't want us in there. So we're in about 75% of the VAs in the country. We're on the federal supply schedule, have been since 2005. So really any government agency can order an Alpha-Stim for their people. So.
Let's talk a little bit about the recent article and the umbrella review that was done regarding serotonin and depression.
One of my favorite topics at the moment, yes.
and the articles and the review seems to suggest that physicians have been suggesting that serotonin is the root of the deficiency or lack of serotonin, the root of depression.
Right.
I used to have this huge book, the Physician's Desk reference book. Mm-hmm. And I remember looking through it so I like pharmacology. Because I learned so much about physiology by reading the mode of action of medications.
Right.
And so that's why I'm always asking, what's the mode of action? How does that work? I'm into the physiology of things. Good. But a lot of the times when I looked at these medications, most of the time, you always had the language that said, it is thought that, it is believed that, evidence seems to suggest that. I don't really recall a straight answer saying depression is caused by serotonin deficiency. Have you come across any literature that actually adamantly says that serotonin deficiency?
I haven't. And actually, I took a continuing education course several years ago that was the instructor was a pharmacist who's also a licensed professional counselor, which I thought was funny. He can fill your prescription and he can recommend that you go talk to your doctor to get a prescription, but he couldn't write the prescription. But he was uniquely qualified for this course he was teaching because he understood depression and anxiety and all the mental health disorders and was a therapist and how to treat them. But he was also a pharmacist, so he fully understood exactly what you said, the mechanism of action for medications and how they work on the body and how they interact with, different things that you're doing or taking and all that. So it was a very, very interesting course. But he said repeatedly, especially talking about antidepressants, we are 100% in the realm of theory here. We don't know. And he mentioned I think there's 7 different types of serotonin receptors they had identified then. This was more than 15 years ago, so I'm assuming there's probably more.
I think last time I read were 15 that they've identified.
Yeah, so at the time they're talking about like 7.
Right.
But they only knew what about 5 of them did. And 3 of them were related to digestion. So, he's like, we really don't know. We think this is what happens. We think that they are increasing serotonin levels. And he said one of the kind of issues with especially SSRIs and medications like that is, we can, and this is the way SSRIs are believed to work, is increase the amount of serotonin in those synapses, but we can't tell the body where to put this increase of serotonin. So it's not like we can say, okay, you're going to take the serotonin and bond it only to the mood receptors. So that's why a lot, and he kind of mentioned this, and right before he mentioned it, I was like, oh, I wonder if, and then he confirmed it. That's why a lot of SSRIs have a lot of digestive side effects, because serotonin is involved with digestion. And it's why depression and anxiety have a lot of digestive and gastrointestinal symptoms, because serotonin is so involved in that.
In fact, the gut has a lot more serotonin than anywhere else in the body. I mean, much more than
exactly. The brain. One estimate I saw said about 85% of the serotonin in your body is actually in your gut.
Right.
So, it's even that. So as you mentioned, if you take a pain med, they can tell you how it works. If you take an antibiotic, they can tell you what it's doing. And that's one thing he described is why we're in the realm of theory when you're talking about mental health disorders is, if they're trying to develop an antibiotic, they can put a whole bunch of bacteria in a petri dish, put that chemical in the petri dish and see how much of it how much of the bacteria is killed by it. They can't put depression in a petri dish, put an SSRI in there and see what happens. So, so as I said, it was a very interesting study, but all the research I've read, and anytime you talk to like a pharmacist or somebody who's really into pharmacology, they'll admit we think this is what's happening. It's I had actually, and I had seen some research before this umbrella review that questioned that. Is this really what's happening? Are we really going down the right path? Are we really telling patients the right information? And then this umbrella review, which looked at, of course, existing literature going back, I believe, a decade, including a genetic study that had, well over 100,000 participants. And their conclusion was that there doesn't appear to be an association between serotonin levels and depression.
Or perhaps that there is no association of serotonin being the only reason for depression.
Right.
Because when I looked at some of the studies or the research on the Alpha-Stim website, and it was indicating that cerebrospinal fluid show higher levels of serotonin after
following a CES treatment. Yes.
Right. So serotonin doesn't last that long. And I think maybe perhaps looking for the metabolites of serotonin might have given a better indication. But the fact is that according to what I read there, they were higher, including other neurotransmitters, beta endorphins and so on.
Right.
So we can't really say that serotonin does not play a role. It's just not the only role.
Right, exactly. And I don't think the human body is so easily categorized as to say one thing causes anything.
Right.
You know, so even, I mean, conditions, like, heart disease, you know, there for a long time, it was, oh, well, diet is the cause of heart disease. Well, okay, great. But what about that marathoner that eats healthy and had a heart attack? There's a lot of factors that play into anything involving the human body. And so I always thought it was an oversimplification to just say, oh, well, it's just serotonin, or it's serotonin and norepinephrine. Trying to say it's only a chemical disorder, I think, takes some of the opportunity for helping people out of it. Because if it's only a chemical disorder, then your only treatment option is medication. And medications work sometimes they don't. Sometimes it takes a long time to find the right combination. I think looking at the electrical activity of the brain with these disorders, and the electrical activity is influenced by a lot of environmental factors, personal factors, genetic factors, as well as we're able to influence the electrical activity in our brains. So, if you've got if we're looking at, say, fMRI differences, and I tell you a sad story, really, really sad story, the electrical activity in your brain is going to change based on that. Maybe not a lot, but it'll change. And as I mentioned earlier, the electrical properties of the brain control the chemical properties. So, and vice versa. It's not strictly a one-way relationship.
Exactly.
It's symbiotic. Everything in the body is symbiotic. So, but with CES, our primary mode of action is that electrical activity in the nervous system. And then by balancing that and affecting that, downstream, it'll have an effect on neurotransmitters. But the primary focus, the primary mode of action is that electrical activity.
Right. So eventually then downstream, there will be some chemical involvement in it.
Yes.
Right. You mentioned earlier about the veteran that you stopped the treatment after about 20 minutes. What determines the dosage? How long should you keep the unit on a patient?
And that's, like I mentioned earlier. So the correct dose for Alpha-Stim is an inverse relationship between the current that they can tolerate and the amount of time they need to treat. So if there's someone like me, they can't tolerate, very, very high levels of current, and high being relative here, because at its highest, Alpha-Stim is about half a milliamp in electricity. So it's still minute. For most people, it is a completely subsensory treatment. Most people, if you feel anything on your ear clips or at where the electrodes are, what you're feeling is the spike in our waveform that's designed to disrupt the electrical activity, or the skin resistance, electrical resistance in your skin. And so that lets our waveform kind of get into the nervous system very easily.
Glad you said that.
Yeah, so that's what you're feeling. You're not feeling the current. You're not feeling the waveform. You're feeling those spikes.
Do you desire to feel the spike?
A lot of people don't feel it, and that's perfectly okay.
I see.
I don't really feel the spikes when I put the ear clips on. What I feel is the dizziness, but I also get motion sickness very, very easily. Mm-hmm. So I think that's what it is. I think anything that starts to mess with influence my inner ear gives me vertigo. So, and I don't know for a fact that's what it is. I'm kind of doing an informal survey when someone calls in and says, hey, I put this on at a level 1 and I got dizzy. One of my questions is, do you get motion sickness easily? And a lot of people say yes, but some say no. So even that's not 100% what the reason is. Right. Just everybody's nervous system is different.
Right.
And so if they can go to 250 to 400 microamps without feeling that dizziness or that discomfort, then they only need 20 minutes of treatment. If they're between 100 and 200 microamps, then they'll need a full 60 minutes of treatment. So
Got it. Got it. Got it. Got it. So when you have the probes in the ear, is there a region of the ear where it's more effective? Maybe there's less collagen, less fat, or more of it?
So you can move it around different parts of the ear to see where it works best. Our recommended placement is on your earlobe as close to your jawline as possible, because there is a nerve cluster there. And so you put it there and it's going to travel, it's going to hit more of that nerve cluster and go into your inner ear.
You mentioned the eighth cranial nerve innervating the earlobe. I have read where at times they were put in, I'm assuming by way of pads, I don't know, on the eyelids.
Yeah, so that was the 1950s or 60s when they were trying to kind of figure out best placement. And so they would do that. They would somehow or another put electrodes on the eyelids and on the back of the brain to get that current going through this way instead of ear to ear. And left to right is the more preferred method now for any CES device. There's some that use sponges on the temples. There's some that use, the big headphones. We use ear clips. They're generally pretty comfortable and unobtrusive. And but they used to do that. And then what they found was like vision blurring and those, the flashing lights.
Right.
Just from the optic nerve it wasn't doing any damage. It was just that optic nerve being stimulated. We still have people now, even with putting on the ear clips, if the current, they may not feel dizzy, but they may see flashing lights from the current hitting their optic nerve. And it's not at all harmful. We just say, go ahead and turn it down until that goes away. So
far out. I have really enjoyed this. I have learned a great deal.
Well, thank you. I have too.
And I want to thank you for taking your time and coming to this. I look forward to continuing to use the unit in my practice. It has helped a lot of my patients. There's a lot to learn.
All right.
And
I'm glad to hear it. And, EPI offers free customer support, clinical support, and technical support for the life of the device. So if they have any issues with their device or trying to figure out how to use it best for them, call our toll-free number Monday through Friday, 8 to 5 Central Time, and we'll be more than happy to help you out.
Thank you very much. I appreciate you coming here.
All right. Thank you.
We'll talk soon. Thank you, sir.
Yes.
Bye-bye.
Bye.